rivers must be claiming here also. Ajay, river check.
Good morning, everybody. Today's topic is surgeon's perspective in liver transplantation for pediatric inborn errors of metabolism. The topic itself is a class for me to go through all these inborn errors of metabolism, but I will try to restrict it for what are the surgeon's perspective and a short uh, visit to the different indications for liver transplantation in this group of patients. So I will go through introduction, classification of the different errors, important IEM for liver transplantation, surgical aspects, a role of LDLT and donor evaluation, and two unique transplant concept of auxiliary partial, orthotopic liver transplant and dominant liver transplant. So inborn errors of metabolism are rare, inherited genetic disorders occurring in roughly 1 in 2,500 births. Defects in the proteins or enzymes prevent the body from properly converting food into energy, leading to accumulation of toxins. Inborn errors of metabolism remains the standard term, but other terms which are interchangeably used for this specific subtypes are inherited metabolic diseases, congenital metabolic diseases, and enzymopathies where a single enzyme is defective and leads to the pathological consequences. Liver transplantation is, as all of us know, is the gold standard for the treatment of end-stage liver disease. Select patients of SCC and ALL. In patients with inborn errors of metabolism, a genetically normal liver can correct the defect by providing a lifelong enzyme replacement therapy. LTX is liver transplant, no established therapeutic approach in these patients, but there are many dynamic changes associated with it. Definitely, it improves the patient's metabolic control and disease burden, reducing the frequency of metabolic crisis and halts the neurological damage. The results of transplants are comparable with those with other indications of transplants in this pediatric age group. Depends. This published in the split registry data. So again, showing the different indications of liver transplant in pediatric patient as per the split registry data, and it is second common indication for liver transplantation, followed by biliary atresia. Apart from that, almost 30 to 35% cases of pediatric ALF have underlying inborn error of metabolism. And the current 1 year patient survival rate almost exceeds 95% in these children, including all types, DDLT, LDLT, and other indications. But this is not that straightforward. There are definite challenges when we evaluate or undertake a child for with inborn error of metabolism for transplant. First is the heterogeneity inherent in these disorders, the way they present, limited to liver with extrahepatic manifestation, the impact of liver transplantation on the disease progress, whether there is recovery from the neurological complication, they will progress or they will remain like that. Then the precise timing of LT, when to perform it, when the child is too small or late, and if you are performing it late, is it too late? Or more importantly, before the manifestation of neurological disabilities. And this is all related to complex natural disease trajectory. And another thing is quality of life, because before transplant also, the quality of life is poor, and some people criticize it that a patient of inborn error of metabolism, it just remains the patient because the disease is changed. And again, the need for lifelong immunosuppression and its consequences, especially when the liver is normal and there is single enzyme defect, and obviously the post-LT outcomes. So I visited this and there are almost 1,400 metabolic disorders which are classified, and it's very difficult. And it's a multidisciplinary approach, and you need a pediatrician to help you before you take any decision. So coming to the classification, which is very close to our interest, we can divide whether the liver is normal or not normal, and whether there are extrahepatic manifestations or no extrahepatic manifestations. So this simplified classification, first we go with that there is a structural liver disease, and that is confined to the liver. The liver has developed cirrhosis, HCC, or present as other patients like decompensated liver disease, or occasionally like acute liver failure. The common one are the alpha-1 antitrypsin deficiency. Next comes Wilson's disease and hereditary hemochromatosis. When there is structural liver disease with extrahepatic manifestation, then again the ball changes, because what we are going to offer. Then it comes the Alagille syndrome, cystic fibrosis, Niemann-Pick type C, mitochondrial hepatopathies, and telomerase biology disorders. Practically for a surgeon, it's very difficult for me to understand all this at present, but I try to simplify. On the right side, there is absence of structural liver disease with enzyme deficiency confined to the liver. This is a very important group, because many proponents suggest that 15 to 20% of a normal liver activity is sufficient to correct the enzyme deficiency. When the enzyme deficiency is, or the problem is limited or confined to the liver, typical are Crigler-Najjar syndrome, familial homozygous hypercholesterolemia, and urea cycle defect. Then the next is absence of structural disease with extrahepatic manifestation with primary hyperoxaluria. Again, it changes the perspective, because the role of simultaneous kidney transplantation comes in. Then the MSUD, maple syrup urine disease, and this organic acidemias. So again, practically, whether a patient should go for a partial APOLT or a standard OLT, or a patient, or whether the patient will benefit with liver transplant, there's again a surgical classification, and which takes the type 1 cirrhotic MLD, metabolic defect causes direct hepatocellular damage leading to fibrosis, cirrhosis, portal hypertension, and HCC. Wilson's, tyrosinemia type 1, hemochromatosis, alpha-1 antitrypsin deficiency, and glycogen storage disease. Type 2 is non-cirrhotic MLD, liver-only principal site of gene expression. Native liver is structurally normal apart from the single enzyme defect. Less than 20% normal activity is usually enough to correct phenotype, and this includes the Crigler-Najjar, urea cycle disorders, FAP, primary hyperoxaluria type 1, then hypercholesterolemia, hyperoxaluria type 1, hemophilia, atypical hemolytic uremic syndrome. Type 3 non-cirrhotic metabolic liver disease, system enzyme, defective enzyme expressed in multiple organs, liver one of them. Liver transplantation ameliorates but does not cure the systemic disease. These are the propionic aciduria, maple syrup urine disease, methylmalonic acidemia, and homocysteine. Please pardon me, I'm trying to simplify it for myself. And so coming to the individual disorders, if we take first is alpha-1 antitrypsin, because it is either autosomal recessive or considered as codominant disorder caused by a mutation in certain gene. It is one of the commonest IM requiring liver transplant because the either end-stage liver disease or ALF. But to a surprise, almost 0.8% of the presumed healthy livers are heterozygous for this deficiency. But the landscape is again changing. What is important in this disorders that fagocitrin and RNA interference therapeutic in adult with this disorder have showed promising results and may change the or alter the indication for liver transplant in this group of disorder. Wilson disease, we recently have a single theme conference, so it's I can just take one slide because it's an extensive topic. It's a progressive copper overload disorder due to mutations in the ATP7B gene encoding a copper transporting T-type ATPase. Liver transplantation, there is a consensus that either a decompensated CLD or a fulminant liver failure. After liver transplant, lifelong normal copper metabolism is restored. The cumulative survival rate is 90%. Potential heterozygous donors should have serum ceruloplasmin and urinary copper levels measured because it's an autosomal recessive. And potential donors with high urinary copper levels are ideally to be excluded because they might be the cases in the pre-symptomatic phase. Coming to the urea cycle defects, this is again a group of disorders. Recurrent life-threatening episodes of hyperammonemia. LT is life-saving therapy that functionally abolishes the metabolic defect and transfers quality of life. LDLT is equal outcomes and restores the normal dietary tolerance and metabolic symptoms. LT had a limited effect on controlling the neurodevelopment outcome in these patients with severe disease because hyperammonemia at the onset time already had a significant impact on the brain, and excellent results observed in this disorder except ornithine transcarbamylase deficiency. This is from the data, Japanese registry data with the longest series, and most of the patients were LDLTs. And the second disorder, which they have described, that doesn't have those attractive results or impressive results after liver transplantation, and that is OTCD. And this is one of the longest series retrospective data of 20 patients of OTCD. 6 had neonatal and 14 had late onset presentations. Almost 75% patients had neurodevelopmental problems. The indications for transplant were recurrent metabolic decompensations, neurodisability, and quality of life impairment. Median age in the early onset was 10.5 and late was 66 months. Overall survival was 95% with 2 required retransplantation. The patients remain metabolically stable, but the neurodevelopment problem persists. Though it doesn't worsen, but it doesn't recover. Also, that's the drawback. And here, the role where we should offer transplant. Another is problem with this disorder. It is X-linked, and we have to be careful when we evaluate the parental donors for this, or may opt for an excuse from a first-degree relative for LDLT. Then again comes the maple syrup urine disease. Is an organic acidemia caused by deficiency of branch chain keto acid dehydrogenase enzyme complex, neurotoxicity due to accumulation of branch chain amino acid. This is a systemic enzyme expressed other than liver in skeletal muscles, brain, and kidney. Liver transplant replaces only a small percentage of the total amount of enzyme in the body, but again, it appears to be curative. Heterozygous donor might not supply sufficient enzyme replacement, and MSUD livers are actually a logical source for domino liver transplants. Coming to tyrosinemia type 1, deficiency of fumarate acetoacetate hydrolase, neonatal hepatic failure, late onset CLD, very high risk, lifelong risk of development of hepatocellular carcinoma. But early treatment with NTBC has revolutionized management. The current indication for liver transplants are late diagnosis, unresponsive liver failure, development of HCC, and if NTPC is not available. Crigler-Najjar syndrome, again, uridine diphosphate gluconosyl transferase deficiency, severe unconjugated hyperbilirubinemia with neurological damage and kernicterus. Intensive phototherapy, almost 24 hours per day, is the mainstay of the treatment. LT provides a functional cure and should be planned before irreversible neurological changes developed. All LDLT, then auxiliary liver transplant, and DDLT have shown good outcome and lifelong freedom from need for phototherapy. Primary hyperoxaluria type 1, the defect in the liver but affects the kidneys. Deficiencies of hepatic alanine glycoxylate, aminotransferase, oxalate overproduction with nephrocalcinosis, renal calculi leading to renal failure. Oxalate is only renally excreted, and as renal injury progresses, oxalate accumulates, resulting in systemic oxalosis with cardiac, ocular, and bone marrow involvement. Usually isolated liver transplant is preferred in the LDT setting when GFR is around 40 to 50, but SLK is mandatory when GFR falls below 30. Sequential transplantation may be preferred in case of living donor, except in cadaveric. If the child is getting a cadaveric liver, it's better to do the SLK than going for a sequential. Heterozygous carriers in the living donor setting have been used successfully as liver kidney and liver kidney donors with similar metabolic correction as seen in cadaveric transplant. Glycogen storage disease, it's a very complex phenomenon and a vast classification, but a group of disorders characterized by hepatomegaly, hypoglycemia, and occasionally cause progressive liver failure. Usual indications for liver transplant include poor metabolic control, progressive liver disease, hepatic adenoma, or carcinoma. The hepatic metabolic derangements are reversed by liver transplant with improved growth and quality of life on unrestricted diets. Many reports have shown that LDLT is safe and efficacious in glycogen storage disease with comparable results. Extrahepatic complications are not impacted by donor type and similar, but there is a doubt how much of them revert. Organic acidemias, this is the systemic accumulation of toxic intermediary metabolites, including methylmalonic acidemia and propionic acidemia. MMA, deficiency of methylmalonyl coenzyme mutase. Then propionic acidemia is a deficiency of propionyl carboxylase. Clinical presentations, neurological, may progress to coma and death. Recurrent metabolic crisis, poor growth, and impaired neurodevelopment. Transplant provides an important partial phenotypic correction, permitting relaxation of dietary restrictions, significantly reducing the risk of ketoacidosis and improving quality of life. But extrahepatic complications, including renal failure and metabolic stroke, persist, and the data is unclear that how much success can be achieved. Homozygous familial hypercholesterolemia. Homozygous is devastating condition resulting in cardiovascular death by second decade, which does not respond to lipid lowering treatment. LT, which reduces cholesterol by 80%. The long-term cardiovascular outlook again for these recipients is not clear. Expanding non-transplant options for this disorder, the use of heterozygous donor can be justified only where there is no other donor available, because it may not achieve the goal. So this is a summary of indication, disease, and when to offer transplantation. So usually these are the prevent or reduce risk of metabolic decompensation, improve metabolic control, prevent, reduce, or organ transplant complications, improve long-term neurological outcomes, improve growth, improve disease burden, quality of life, prevent ALF or recurrent acute liver injuries, treat end-stage liver disease, treat liver cancer, attempt to treat an unsuitable disease, selected cases. Only most of the cases, to summarize, that warrant early liver transplant so that the neurological complications can be prevented. Only when the diagnosis is late or there is development of SCC, late liver transplantation can be considered. So coming to LDLT, is increasingly being performed. Careful donor evaluation is important. Most inborn errors of metabolism have autosomal recessive traits. Living donors are generally blood relatives who are obligate heterozygous carriers of the disease. Pose the potential risk of the donor graft having inadequate metabolic function, preoperative genetic assays, and parental donors with HLA homozygosity needs to be addressed. This is the relative risk of using grafts from parental donors. First comes the ornithine OTCD, that is X-linked, 1 in 17 to 80,000 births. Marginal parental donors is the heterozygous mother, and the risk is the persistent of hyperammonemia. Then protein C deficiency, again heterozygous parents, thromboembolic events after transplant. Then familial hypercholesterolemia, which is homozygous, then a heterozygous parent may not correct the deficiency completely. Acute intermittent porphyria, autosomal recessive, heterozygous relative decrease in phosphobilinogen minus activity, then erythropoietic protoporphyria, again the heterozygous relative, there is decrease in the activity of the enzyme replace. Alligali syndrome, this is asymptomatic, but there might be some biliary changes, and the MRCP is mandatory before taking a graft from here because there is a risk of cholestasis after transplant. Hepatorenal fibrocystic disease, and all living donors, it's better to go for HLA matching because homozygosity is associated with graft versus host disease. So the donor evaluation protocol, as we follow in the first part, second part, specific to the disorder, urea cycle disorder, genetic analysis to exclude heterozygous OTCD mother. Then congenital deficiency of protein C to exclude the heterozygous donors. Same for familial hypercholesterolemia, porphyria, Alligali syndrome assessment, particularly of the MRCP or liver biopsy, and genetic analysis of asymptomatic donors. Again, hepatorenal fibrocystic disease, same to rule out multiple liver cysts and determine whether they are connected to the bile ducts. Wilson's, organic acidemia, alpha-1 antitrypsin deficiency, Crigler-Najjar, primary axilleria, or maple syrup urine disease does not require additional evaluation. So coming to the truly surgical perspective about the recipient operation, liver transplantation in patients with metabolic disease, especially in which the liver is essentially structurally normal, then there are specific issues because the liver is not cirrhotic. There is no ascites. There is no the abdominal cavity has almost normal dimensions, and there is no portal hypertension particularly. So these patients do not tolerate portal or systematic clamping as a patient of CLD will do. And so that's why we have to keep the clamping time at as low as possible to prevent the intestinal congestion and hemodynamic stability. Then in case of metabolic diseases, the donor-recipient dimensional matching is more important because small children and they don't have portal hypertension, there is no hepatomegaly. And so we have to not only just the graft to recipient weight ratio, but we have to be more restricted to avoid the large pore size syndrome, which increases the vascular complications and primary non-function or early allograft dysfunction. Neonatal LF is another challenge. The available space is really low, and reduction or hyperreduction techniques or monosegment transplant techniques to be followed. In case of DDLT, the donor characteristic and ischemia times must be so adjusted so that there is a prompt functional recovery of transplant organ to reduce the risk of acute metabolic decompensation. It is like liver not working, but that manifests as the acute metabolic dysfunction that has to be kept in mind. Perfusion machines or normothermic machine perfusion can help in this, but data is still upcoming. Coming to the interesting part or type of transplant, that is auxiliary partial orthotopic liver transplantation. In this, a part of the liver, usually a left hepatectomy performed in the recipient, and a left-sided graft is implanted in the same area. It's an advanced LT technique in which segmental or sectoral graft is implanted into the orthotopic position while preserving a portion of the native liver. In the context of ALF, APOLT has been described, and the purpose is that if the native liver regenerates, then the need for lifelong immunosuppression can be avoided. It was typically described in patients with paracetamol poisoning or viral hepatitis. But children with, why to do it in children with non-cirrhotic metabolic liver disease? Because this partial graft is sufficient for the metabolic correction while preserving the native liver for future therapies, because it's just a bridge to the future, what the authors have described. Because if any gene therapy or pharmacological therapy becomes available or a hepatocyte transplant becomes available, then the patient can be cured with his native liver and the immunosuppression can be stopped. So the unique problem associated with this APOLT is the portal steal phenomenon that may lead to the graft atrophy, and the pioneers have described this three-level technique. First, that is called graded hemiportal banding in left lobe APOLT. First, the portal pressure being measured in the remnant liver after left hepatectomy, that is the right liver. P2 after implantation of the graft in the main portal liver. Flow to the liver. This should be less than P1. P3 is the portal pressure in the graft. It is measured after clamping the portal venous pressure of the right lobe. In patients with non-cirrhotic MLD, the graft portal pressure may be higher. In these cases, a graded banding of the remnant liver is performed until the portal pressure of the remnant is higher than that of the graft. Because if the pressure on the remnant liver or the native liver remains on the higher side, there will be portal steal and the graft will get atrophic. And the problem with this is that if the graft gets atrophic, the problem, it doesn't manifest with any derangement of LFT, but the purpose for which the metabolic derangements will not get cured. Similarly, arterial reconstruction, there is a disconnection, actually anatomical disconnection between the right lobe and left lobe to make it simple, so that again there is no steal phenomenon and the graft is maintained individually. So another interesting concept is the domino transplant for pediatric liver recipients. This involves 3 consecutive but at the same time overlapping operations. In explanted liver from deceased donor has approximately 15% normal enzyme activity is enough for MSUD patients. Explanted enzyme deficiency liver from MSUD patient is compensated by approximately 85% normal extrahepatic enzyme activity in domino recipients. Though this is not exactly as for the benefit of these patients, but the MSUD grafts can be used as domino for benefit of other patients. So this is the summary of the diseases in which domino transplantation has been attempted. First is, all of us know, is FAP, familial amyloidotic polyimine neuropathy. Then the MSUD, as I have just described. Then familial hypercholesterolemia, primary hyperoxaluria, MMA, propionic aciduria, ornithine transcarboxylase deficiency, and Crigler-Najjar syndrome. So domino and auxiliary. This is another interesting case which recently has been first described in 2017. Then a series has been described that domino and auxiliary transplantation can be used together. The 2 domino grafts with different metabolic liver disease could compensate for each other's metabolic defect. A domino graft from a child with Wilson's disease and a second graft from a child with OTC deficiency were successively implanted into an adult woman with FAP, and the authors reported almost a 4-year follow-up asymptomatic. Then domino cross auxiliary using non-cirrhotic metabolic graft for auxiliary transplantation in other patients with an alternative type of metabolic disease. 2 partial livers are exchanged or swapped between 2 patients with different non-cirrhotic metabolic disease. In this way, LTX can be performed without a healthy living donor or a deceased donor. And this is unidirectional, means that liver with the systemic metabolic disease used as the donor graft should be transplanted to a recipient with a single liver metabolic disease and not for cirrhotics. Then this is the technique, surgical procedure, and the refinement of implantation of the domino graft. First is the left lobe with MHP recipient common trunk, as usually done in the left lobe liver transplantation, but here the complexity increases because the right-sided liver is still there. Then the second is the portal vein implantation. Usually it is a separate implantation in the main portal vein. Then there is the arterial disconnection and the implantation of the left hepatic and a Roux-en-Y hepaticojejunostomy for the ductal reconstruction. So this is a series of almost 6 patients who have undergone these patients and received this auxiliary domino cases, and they have reported survival with some problems, only one death because of a surgical issue. And another interesting case, what I brought to, because though it's a case report, but it's a lot of science in this. The metabolic chimera into defective genotype, making a normal phenotype. First patient with a PA O positive, second patient Crigler-Najjar syndrome A positive. First patient underwent APOLT and left hepatectomy was done, and mother was the donor. The left hepatectomy specimen of the first patient was implanted in patient 2 with Crigler-Najjar after performing a left hepatectomy and thereby completing the domino auxiliary transplant. Both the patients have uneventful recovery with no manifestation of either PA or with a normal ammonia. So this is Dr. Rela's publication long back, 2015, how a patient post-operative CT. This is domino graft deficiency in propionyl carboxylase, and this is a native liver with Crigler-Najjar, and both are compensating each other's enzyme defects. And this is the normal phenotype. To summarize, liver transplantation is the treatment of choice in children with inherited errors of metabolism. LDLT offers excellent outcomes. Careful liver donor selection is important. Experienced transplant surgeons in view of normal recipient livers without portal hypertension, auxiliary partial liver transplant, technically demanding and considered bridge to the future. Domino liver transplant definitely increases the organ pool. Thank you. Yes, sir.
I think we should move forward to do dominoes or auxiliary. Both are required, and I think the outcomes should improve.
Yes.
No doubt about it. Okay, if no more comments, we'll go to the next presentation. Thank you, Shri.
Good morning, everyone. So today I'm going to speak on opioid risk and use in liver transplant recipients. So as an anesthesiologist, we are actually the gatekeepers for the perioperative exposure of opioids to these patients, those who are undergoing surgery, especially in the liver transplant recipients, where the graft function is evolving and recovery is very critical. Every opioid decision is going to have an impact on the post-transplant outcomes. So it becomes very, very important to have a balance between the adequate analgesia and opioid-related side effects such as the respiratory depression, prolonged ventilation, and long-term dependence on the opioids. Therefore, the opioid stewardship in liver transplantation is not merely a strategy, but it is also an ethical responsibility of an anesthesiologist and the complete team because it is going to have a direct impact on the liver transplant outcomes. So my today's presentation will cover the ongoing opioid epidemic in USA and whether there is epidemic in India also. Then I'll cover briefly about the incidence and prevalence of pain in cirrhosis and what challenges we face while managing the pain of these patients who are very complex patients. Then about the opioid use and post-liver transplant outcomes, how it affects the post-liver transplant outcomes. And finally, about the opioid sparing pathways. And I'll also discuss about the various non-opioid options which can be used for the treatment of pain in these patients. So why is today's talk so important? According to WHO, worldwide, there are annually around 0.5 million deaths occurs due to the drug use, out of which 70% deaths are due to the opioid use, of which 30% deaths occurs due to the opioid overdose. As per this data, the United States has the highest estimated number of drug-related deaths per million population aged 15 to 64 years at around more than 300 deaths per million population, which is far more than the other countries. Even countries like Australia, Canada, and parts of European countries, they have reported very high mortality rates with the opioid overdose. So it is not merely a Western problem, now it is a global health problem. So delving more into the United States epidemic, around 70,000 deaths occur annually in 2019, out of which 48,000 deaths occur due to the synthetic opioid overuse, which was mainly the fentanyl. And around 1.6 million people, they misuse the pain prescription for the opioid use. According to CDC, that is Center for Disease Control, around 217 people died each day from an opioid overdose in 2023 in the United States. So the opioid epidemic has evolved through three waves, and these waves are actually overlapping, creating the epidemics within the epidemics. The first wave started in 1990s, and which was due to the overprescription of the opioids. Then the second wave evolved through 2010 to 2013, and it was due to the rise in heroin overdose deaths. And the third wave began in 2013, and it was due to the rise in synthetic opioid, which is mainly the fentanyl. So now the important question is, where does India stand? In India, about 2.1% of India population, it uses opioids. The overall prevalence of opioid use in India is estimated to be around 3 times the global average. While this overall prevalence is less, but the absolute burden in a country of our size is enormous. Looking at the state-wise data in India, Uttar Pradesh, Punjab, and Haryana, they contribute to the maximum number of people who need help for the opioid-related problems. And it also signifies that it is not just a Western problem, now it is very much into India also. Now, this is an interesting study where they tried to find out whether there is an opioid epidemic in India, and they said that the opioid epidemic in India is there, but it's not yet physician-induced. Much of the problem about the opioid is due to the misuse of opioid rather than the prescription-based. Now, coming to the pain in cirrhosis is very, very common, and around 40 to 80% of the chronic liver disease patient, they complain of pain during the course of their disease, and yet managing pain is particularly challenging in this patient. There are certain reasons why the pain is so challenging in these patients. First is the nature of the pain. It is very difficult to assess the exact nature of the pain, whether it is originating from the musculoskeletal or visceral or neurogenic, or it is centrally mediated. And the other concerns are regarding the side effects of the opioids and other complications like the renal dysfunction and the presence of hepatic encephalopathy. In fact, there is no consensus or the guidelines which suggest how to manage the pain in these patients. And importantly, these patients, a subgroup of these patients, they have a high rate of substance use disorder, which also complicates the pain management of such patients. Now, this is a retrospective analysis of around 5,000 patients, where they found that almost 32% of the chronic liver disease patients, they reported pain at their initial visit to the hepatology clinics. Out of these, 25% had moderate to severe pain. And the abdominal pain was the most common site for the pain, which was far more common than the pain at the other side. And they also found that the patient who had a pain, they had more number of decompensation. So they had a poor prognosis in comparison to the patient who did not complain of any pain at the initial visit to the hepatology clinic. Now, in cirrhotics, opiate pharmacokinetics is often altered, and the major reasons are the photosystemic shunting, renal dysfunction, and the hypoalbuminemia. And there are also concerns with respect to the precipitation of the hepatic encephalopathy, since the brain in cirrhotic liver disease patient becomes very sensitive to the opioid use. So cautious use of opioid should be there while managing the pain in this patient. This is a national cohort study where they included 6,451 well-compensated cirrhotic patients, and they found that out of 6,000, almost 28% of these patients were using the opioids. 22% were using the opioids for the short term, while 4% were using the chronic opioid. And they found that almost 6% of the chronic opioid users, 5% of the short-term opioid user had developed hepatic encephalopathy over a period of 1 year when compared to the 3% patient who had never used opioids. So this table summarizes the risk associated with the opioid and benzodiazepine in patients with cirrhosis and those who received liver transplant. Patients who had received opioid in the pre-transplant period are likely to have higher incidence of hepatic encephalopathy and more increased hospitalization stay, while decompensation and mortality data is lacking. About the post-liver transplant, there is a definitive data which suggests that if the patient is using opioid in the pre-transplant period, there are increased chances of graft loss and mortality. This table summarizes the various predictors for the opioid use in the cirrhotic patient. As we can see here, in general, younger population, hepatitis C etiology, more advanced disease, hepatocellular carcinoma, and more medical comorbidities are important predictors for the opioid use in these patients. In fact, pain has also been found to be an important predictor for opioid use in the cirrhotic patients. So this is a large national cohort study where they recruited almost 1 lakh patients, and they found that the cirrhotic patients, particularly the decompensated patients, they were less likely to receive the acetaminophen and the NSAID-based analgesic, and they are more likely to get treated by the opioid-based analgesic. So this is an interesting study where they found the prevalence and the patterns of opioid use before and after the liver transplantation. As we can see here in this graph, the incidence of chronic use in opioid naive patients after the liver transplantation was around 4.2%, while the incidence of intermittent use was around 50%. And these are those patients who were not consuming any opioids in the pre-transplant period. So this is another study where they recruited the patients of kidney transplantation, liver transplantation, and simultaneous liver kidney transplantation at 3 different centers. And they found that the patients who had undergone the liver transplantation and simultaneous liver kidney transplantation had the highest or the largest prescription of median morphine equivalents. In the multivariate analysis, they also found that it was mainly this transplant center, which was a significant predictor of opioid overdose prescription, especially for the kidney and the liver transplantation. However, they found that the increased age and the increased hospital stay, they were the protective factor for the opioid overprescription in patients who are undergoing the transplantation. A couple of studies about the opioid use and the post-liver transplant outcome. This study is from a transplant registry which has spanned over 5 years, and they tried to find out the impact of the pre-transplant and the post-transplant opioid use on the post-transplant mortality and the graft loss. And they found that there was almost 50% increase in odds of graft loss and 40% increase in odds of mortality in a patients who were consuming the opioids in the pre-transplant period. So this is another study where they recruited almost 446 transplant patients. However, in contrast to the previous study, they did not find any difference with respect to the mortality and the graft loss, but they said that the influence of opioid use on outcomes is based on the MELD score. The patient who had a lower MELD score, they were more likely to have a poor outcomes if they are consuming opioids in the pre-transplant period. And this is another article where they try to find out the relationship between the pre-operative opioid use and the post-operative opioid consumption and the post-surgery pain. And they found a significant correlation. Again, they found a very significant difference between the opioid user and the non-opioid user with respect to the opioid consumption. And in fact, they have also found a difference in the mortality, especially the patients who had developed a chronic pain syndrome after the surgery. They had a higher mortality when compared to the patient who did not develop chronic pain syndrome after the surgery. This study is from our institute, from our department, where we try to look into the fentanyl consumption after the liver transplantation. And in contrast to the previous study, the fentanyl consumption we saw was very less. It was just 100 microgram in patients where the MELD score was less than 25, and around 62 microgram in patients where the MELD score was more than 25. And this was statistically significant. We also found that the fentanyl consumption was mainly based on the MELD score of these patients, which actually signifies how advanced is the liver disease. Since patients with the advanced liver disease, they are likely to have a higher level of endogenous opioids, so they are likely to consume less opioids in the post-transplant period. So these are the 4 main pillars by which we can reduce the harmful opioid use. First is to assess the pain and the other symptoms. All patients, especially the chronic liver disease patients, they should be assessed for anxiety and depression, and they should be referred to the pain clinic and the palliative care clinic as soon as possible. Secondly, minimizing the highest risk opioid use is also should also be done. and the patients who are vulnerable should be identified. Third is to apply the safe prescribing strategies, which includes to start with the lowest possible dose of the analgesic and to reassess it frequently and titrate it slowly. And consider methadone and the buprenorphine for the treatment of the opioid use disorder whenever possible. And also try to use the opioid sparing pathways, especially after the post liver transplantation. Finally, opioid use disorders, they are very common among these patients, so it's important to diagnose and treat them properly with methadone and buprenorphine. If they are on methadone and buprenorphine, it does not make them contraindication for putting them on the list. In fact, they can be taken for the liver transplantation while they are on the treatment for the opioid use disorder. Now, these are some of the options for the non-opioid management in the cirrhotic patient. One is the acetaminophen. We all know that we can use it up to a dose of 2 grams per day. Then NSAID, obviously, they have to be avoided in these patients because of the risk of renal dysfunction and the bleeding risk. Gabapentin and antidepressant like the tricycline antidepressant, they can be used safely in these patients. While the evidence on the cannabis is lacking, however, it should be avoided because of the risk of dependence on cannabis. And whenever possible, try to use the peripheral nerve blocks and other techniques like the acupuncture for the treatment of pain in the cirrhotic patients. Now, this is a interesting study where they try to follow a strategy for reducing the post-op liver transplant opioid consumption. They made opioid avoidance pathway and they applied this pathway and they tried to look whether this can reduce the opioid consumption in the post-transplant period. And they found a significant reduction in the post-transplant opioid consumption in the patients where they have applied the opioid avoidance pathway. However, the pain scores in both the groups were comparable at all time points. So this was the opioid avoidance pathway which they have followed in their study. It was developed by a multidisciplinary team of anesthesiologist, surgeon, hepatologist, and social worker and the physiotherapist. In this before transplant, surgeon explains completely about the expected recovery trajectory after the liver transplantation. Pharmacist optimize the non-opioid strategies and the psychologist evaluate the complete pain behavior of the patient. In the preoperative period, oral gabapentin 600 milligram is given to all patients 2 hours prior to the surgery. Intraoperatively, as far as possible, try to use the minimum amount of fentanyl and the ketamine infusion in a dose of 0 to 70 microgram per kg can be used. In addition, bilateral incision catheters with a ropivacaine infusion at 6 ml per hour can be used. So post-operative, they have given the opioid-free analgesia, which was mainly based on the ketamine, gabapentin, and acetaminophen. And the rescue analgesia was given with the tramadol, buprenorphine, and morphine, initially with orally dose. Then later on, if still the patient has a pain, they have given the IV buprenorphine and the morphine. So what is our protocol for with respect to the opioids for the patients who are undergoing the liver transplantation? Intraoperatively, we give fentanyl at a dose of 1 to 2 microgram per kg per hour as a continuous infusion to all the patients who undergoes the liver transplantation. In the post-operative period, we try to keep them the opioid-free sedation, where we use only the propofol at a dose of 1 to 2 milligram per kg per hour. Along with that, we also give paracetamol 500 milligram TDS. And for rescue analgesia, we keep gabapentin 300 milligram orally or fentanyl 25 microgram IV as well. So take-home message is that opioid exposure in liver transplant recipient is not benign. It is associated with increased complication, prolonged recovery, and risk of dependence. Multimodal pain management should be the standard of care in programs to minimize unnecessary opioid use. Personalized pain plans are essential, especially for high-risk patients. Combine multiple strategies such as preemptive non-opioid analgesics, seasonal anesthetic techniques, early post-operative physiotherapy for optimal outcomes. The goal is to have zero pain with minimal opioid exposure. Thank you very much for your attention.
Very crisp and nice, Gaurav, and I'm happy we have less of fentanyl and we use paracetamol or gabapentin. Maybe we can also use tramadol, I don't know, which we use at least in hepatology. Any comments? If not, we have presentation by operations. So while you're going up, it's a problem you feel in India, Gaurav? The opioid use is a problem?
Definitely, I've shown a lot of literature here.
Or in the transplant groups?
The transplant, as such, I didn't find any study where they try to look into the pre-operative opioid use in these patients. So that could be actually very good study if we can plan.
We have our de-addiction clinic and we have experts on substance use. Maybe Akanksha, am I right? Akanksha and Mohit can look into it and give comments on this. This will be interesting. All alcohol users, whether they are also opioid users or not. Thank you, Gaurav.
Thank you.
Tomorrow we have visit from the French delegation. The head of the ANR, a large agency, is coming in the morning around 11 for a brief while. And then activities throughout the AI summit will go on. The 20th, there is a AI liver health summit here at ILBS starting at 8:45 also. Okay. So Dr. Rastogi, over to you.
Sure. Before we start, I just have to make an announcement. ILBS has the responsibility of providing medical cover for this ongoing AI summit, which is a matter of great pride for us. And we have already taken out some office instructions about this. Some of the key functionaries have already been briefed about the thing. And I'll request all the faculties who have been nominated, since their number is been given, so to remain alert in case any call comes and all, and provide the adequate response which is required. Some of the resources have been allocated for this particular purpose. Like we have allocated some beds in ICU and 5th floor and in emergency, plus our ambulance will be ready for this exercise. तूने फिर सबेटास कर दिया मॉर्निंग में सारा ट्राई करके गए फिर क्या कैसे ट्रांसफर करेंगे ट्रांसफर कैसे करेंगे नहीं पुराना बदल एनीवे पुराना दिखा नहीं लगता anyway let the presentation not be there. First and foremost, last time we had spoken about the call center. Secondly, based on the inputs from call center, since we had number of patients who have been waiting for us, so for them we have really made a good program in which our call center is giving them appointment in waiting, and so far almost 360 patients have been accommodated like this, and around 2,100 patients had approached us. There were two ways for patients to approach us. One was through the call center. Second was we had given a link on the website itself. And we were quite surprised that during past 20 days or so, the response, the people hitting our website was maximum 10%. They were interacting and hitting because of this purpose only. So it's a great this thing. And in that, since that day, there was certain confusion that how we are triaging. I have already spoken to heads of the department, and in case required, we will be taking help from junior consultants / residents of the particular department to allocate priority or doing the triaging of these patients. Apart from this, there are two more. Apart from this, there are two more things. One is that 3rd October 2025, CGHS rates had been revised, and this revision was after 2003. So the revision was to quite a significant extent, and this had come from Ministry of Health and Family Welfare. Later on 18th of December, Delhi government has adopted and given us instructions to follow these rates, this tariff for all the CGHS and DGEHS beneficiaries, or the services which have been empaneled based on that tariff. So accordingly, from 1st February onward, we have implemented those tariffs, and in that, our OPD consultations charges have also been revised from 400 to 500. But most of the packages are now in line with ILPS
Is the
package.
CGHS rate for OPD, CGHS tariff?
CGHS tariff for the OPD for our hospital is rupees 750.
750, and what have we done? I can't hear.
We have made it from 400 to 500.
500, we are still lower than CGHS. That's okay, not bad.
One is that. Secondly, ILPS is going paperless now. So, there are many benefits of any paperless organization. So, we have taken a lot of steps. In fact, 2-3 departments have already become paperless and a lot of work is going on. Some of the infrastructural requirements were there, like, providing tablets and all. Everything is in process and very soon it will be implemented on ground. The current HIMS is fully versed with complete, like you can put in all kind of electronic medical record. And the best thing is they have provided us the facility in which whatever way you want to put it, they will make a template according to your login ID, according to your choices. So people have apprehension that will take a lot of time. It is only for first 2-3 cases maybe. After that, automatically there will be auto suggestions. And with these auto suggestions, we will be able to, enter data very easily. And so my request with everyone is that kindly use this EMR facility to a maximum. And otherwise, other processes in registration, dialysis unit and all, and even our daycare, this albumin daycare, they are already paperless. So my request with everyone is that kindly follow that. In that, we have taken one more initiative. Dr. Shantanu has made a nice program of referral system. Right now for referral, there is a form which is to be filled, and this form is taken by a GDA to the front desk, who later on, from there, they keep on calling people, and people may respond or there might be delay and all. But right now, what we have done is we have made a nice email-based program in which people will get a call on their email itself, and the total process taken is only 3 minutes. We have tested it on many patients. We have tested it so many times. It takes only 3 minutes. You can enter data from your system. You can enter data from your mobile, and the respective consultant / the SR, they will get the referral message in their email, and they can respond. This has got even facility of uploading the documents and all. So we have worked a lot on that, and this is fully operational. Only thing is, if everybody, approves and they follow, we can implement it from tomorrow itself. It's all in place. And with that, whatever response you have given, even that will come on the email itself to the person who has referred the patient. At the end of the day, person, the consultant / SR, they can see in their mail that how many referrals were there, how many are pending, how many have been responded. So all these things are moving on. So I'll request everybody to, cooperate with us, and we can start this process.
Thank you, Dr. Stogi. So 2 messages clear and strong. One is we are paperless from 1st of March. So IPD, OPD, endoscopy, everywhere, hopefully we will have people, data entry operators who will enter. So we have all moving tablets rather than files and others. And second, the referral system that you have shown. Maybe next week again you can give, preload it and then see how it works.
Sure.
Thank you so much.
Right.
Thank you.
Thank you.